Many American Indian and Alaska Native people draw strength from culture and tradition. Their resilience is built through culture, spirituality, shared values, and a strong sense of identity. Culture serves as a protective factor in the health and well-being of American Indian and Alaska Native people. Understanding and respecting the unique needs and cultural practices of each patient is an important part of building trust and providing medical care. The Hear Her campaign invites healthcare providers to learn about providing culturally appropriate care to American Indian and Alaska Native people who are pregnant or postpartum.
What a wonderful panel we have today. I'm Juliana Reese. I'm Navajo from Fort Defiance, Arizona. I am a family medicine physician by training, and I'm currently the director of Healthy Tribes with the CDC. I'm very honored to be here to speak with you today.
My name is Doreen Day. I'm a traditional practicing midwife, and I have been involved in training. I've been involved in development of culturally appropriate and also cultural safety curriculums to teach medical practitioners about Indigenous people and their needs and how to serve them. But for the most part, I'm the director of a program in White Earth, Minnesota, and it's basically reconnecting and building access to our traditional and spiritual practices that lend themselves to our health. Thank you.
My name is Dr. Soshaleb Thurman, and I am a citizen of the Cherokee Nation of Oklahoma. And on my mother and my father's side, I am Yuchi on my mother's side and Delaware on my father's side. And I originally grew up in Tahlequah, Oklahoma, and among the Cherokee Nation, and found myself getting my training in Minnesota, New York people, and then on to Seattle, where I'm currently located. I'm a family medicine physician by training as well, with several of my years having done obstetrics in the hospital and also in the clinic, doing prenatal, postnatal care, and pediatrics. And I currently serve as the Chief Health Officer for the Seattle Indian Health Board. We are an urban Indian organization and also a federally qualified health center. So we serve all people, but we like to say that we serve them in the native way.
I'm Tina Patara Lau. I am the maternal child health consultant for the Indian Health Service, OBGYN by training. I'm actually trained in the Navy alongside midwives for most of my career, and been honored to work with Indigenous midwives in the Indian Health Service. And I continue to provide care in the Phoenix area, where I've been for the last 8 years, both in the urban hospital as well as out in the rural clinics. It's an honor, of course, to be here. My goal as the maternal child health consultant is to really lift up the voices of the community. I took on this role to really speak truth for our patients, and hopefully in doing that today. So thank you again for the opportunity and the honor, and to learn from you all today.
Well, thank you all.
We are here today because we lose too many American Indian and Alaska Native mothers each year from complications related to pregnancy. As you're all aware, it's important to acknowledge the trauma and systemic barriers that are linked to the disproportionately high maternal and infant deaths that many tribal communities experience. American Indians and Alaska Natives' maternal health is impacted by the historical trauma of systemic racism, colonization, genocide, forced migration, reproductive coercion, and cultural erasure. Despite these challenges, American Indian and Alaska Native people continue to be resilient and thrive. In our work, we focus on the strength of American Indian and Alaska Native culture and tradition. It is a priority for us to work towards reducing health disparities and improving the care and outcomes that we see in American Indian and Alaska Native populations. Providing culturally appropriate and unbiased quality care is often regarded as a critical pillar for eliminating inequities. can you share what culturally appropriate care is and the similarities or differences between culturally appropriate care, cultural competency, and cultural safety?
I'll begin. So for myself, I feel like culturally appropriate care is that it's important to connect the beliefs and holistic healing practices of our own people, because that generates health and well-being, not just for that woman and that baby, but it generates a longevity toward better health care, better health practices, safer health practices in the sense that culturally appropriate care is done in a way that is acceptable to them. Cultural competency can be viewed, in my view, as someone who knows enough to be respectful in providing care, but maybe not have a full understanding of that particular Native person or their tribe or their language or their history or anything else, right? And then cultural safety, to me, means that the medical practitioners have taken a long time to develop their skills in terms of dealing and serving the Native populations. And so they become better skilled at providing that service or that health care.
I think culturally attuned or competent care to me is really about trying to bring people along to educate our non-natives in the best ways to approach our people and really try to change those narratives from a deficit-based to a strength-based approach, knowing that we've been doing this for hundreds of years and allowing people to trust us and our bodies to do what they were made to do. And a lot of that comes from education. It comes from listening. It comes from humility, stepping back and being willing to change some of the things that maybe you knew or were brought up in and be able to shift or have a different perspective. So I think it's an openness that's really, really important. If I worked with a tribal community, I think my first job would be to know the history of that community and to really try to learn some of the language. Taking care of urbans, we take care of so many people. I think it's really about just trying to be open and willing to learn about the different people and tribal nations and languages that you're going to see.
What we're really talking about is just understanding that there are different ways of doing things and different ways of knowing that come from different peoples across the world, and working in a situation that may be different, or with a belief system that may be different from your own. It's really important to just be open about that and to be curious, to really kind of think about a different way of doing something and acknowledging that exists and that your way may not be the only way or the right way. And so starting from that platform, I think you have the beginning of creating this cultural safety, this place where you can have a patient enter a conversation with you or an experience with you as a provider or as a community member and really feel like that person feels safe telling you if they have a cultural belief that may be different or a request that may make them feel more comfortable throughout this experience. And being able to have a patient divulge something like that to you is really powerful. And oftentimes we don't see that. We see patients who are reluctant to tell you their beliefs or to open up and expound on their fears and their concerns. And so if we can try to remove some of that and really open up the platform, I think it really just begins with being open and being curious about other ways.
As women, pregnant persons have been birthing for many, many centuries. They know their bodies best. They're able to advocate, listen to their bodies, and with the support and the guidance from their aunties, their grandmothers, their birth support persons, they're able to communicate with you as a provider. So that is the opportunity to take a step back and listen and ask the questions. How would you envision your birth process to go? What is important to you from your tradition and culture that you would like me to bring in with us in this moment? Allowing ourselves to be vulnerable in learning, but also showing that vulnerability to let the family know, I'm here for you, I will hold space for you. and build that trust that, as you spoke to, has been something we've really worked hard to develop.
I think the thing that I heard a lot about what you said was just being proactive. Because like you said, so many times people want to share, they kind of have those ideas of what they want for their birth, but they're really scared to say it, to speak up. And certainly if they don't have a doula or somebody who's there to speak with them or for them sometimes when they need it, I like how you approach, like, just ask right from the beginning. And part of that is building relationship, right? So much of what we do and the way we do it so well is that it's all about relations. And I think that really goes against a lot of the way that we were trained so many times, because I feel like the way we're trained is really, the focus is on the provider, the nurse, and the patient. And what we're missing is everybody around them, their village. And so I will see so many times that people just completely forget about all the other people in the room, and they don't proactively ask those questions about what people want. And we don't want to underestimate the value of all of those other people and their wisdom and what they're bringing into the space too.
If someone comes into triage and they were complaining of chest pain, okay, let's hear more about the story. Let's take that deeper dive. Let's take those extra steps. This is not just the patient who's in triage bed 1. This is not the patient who's in room 32. This is a family member. How would you want your family member to receive that care? Take the pause, because we forget that so often in our training and in our day-to-day. Take the pause to remember, what is the care that you would like to receive? What are we missing here?
When I was hired by my tribe, they basically said, we need you to create access to whatever it is that's culturally relevant for Anishinaabe people. And I said, well, that's like you're talking about from birth to going back home then. Meaning that when you're born, you come from the spirit world, and when you're called home by the Creator, you're going back to the spirit world. It's a lifespan. The work of a midwife is to be there, to watch life come into the world, and to help when necessary. As a cultural trainer, I gathered a team of people where I work now, and we are providing cultural access. We're providing cultural access not only to our own people, the Anishinaabe, but to the communities that they live in, to the community centers, to the ceremonial centers that they go. But the idea is to be who we are again, to identify as Anishinaabe, the one that the Creator brought into life, brought to this land, put us on Turtle Island with our own belief system, with our own ways of being in the world, our own original way. And going back to that with our language and our music and our songs and our healing. We still have our language, we still have our songs, we still have our practices.
When you use the term traditional ways of knowing, or ways of knowing in general, elaborate a little bit more on what you mean by that.
When I think about it, I think about the ways that we are brought up as Native people. We are always thinking about ourselves in the context of creation. And so, I am myself, but I am a part of this land, our animal relatives, our people relatives, our ancestors, and our generations to come. I think it's the way that we enter into the world, knowing that we are a part of that. We are a pivotal part of our community that we build.
In the Western perspective, oftentimes there's this perception and this notion that you are an individual in self, and self is so important, in that you have responsibilities to nurture that self identity. And that's somewhat contradictory to a lot of traditional Native ways of thinking, because again, you're part of a system, not only the past, not only the future, not only the present, but all the elements, the earth, the land, the water, the air, the animals, the humans. And so understanding that and being able to use the knowledge that our ancestors have had for generations and thousands of years is something that I think is important when you're talking about traditional ways of knowing. We've had traditional medicine, we've had science, we've had so many things that were either stripped or rebranded or taken from us or completely erased. And so these traditional ways of knowing and the knowledge that we carry through our ancestors and through our traditional practices is powerful and needs to be supported and enhanced and instilled. And I think when we talk about that notion, it's as though it is equal to any other ways of knowing that are in existence, and helping providers and even community members understand that really helps people be a little bit more bonded to community and to our existence here as part of this earth and this land.
So one example of what happened last week with one of our prenatal relatives was that she was about 40 weeks, almost 41 weeks, and she was just really ready for this baby to be born. And so she was sort of asking if there were any other things, that she could think about. She'd had some primrose that was given to her. And so I looked over at our traditional medicine apprentice and said, "Do you have anything like red raspberry leaf tea or anything like that?" And he said, "Yeah." So he ran off to get it, and he brought it back and was able to share that teaching with her and provide her that tea, as well as a smudge just in her visit. And so I think just those if they're not little, those ways of integrating our traditional ways of knowing are as important as the clinical care that we're doing. And so some of the things that we've been doing in our clinic, we have something called our Indigenous Knowledge Informed Systems of Care. And it's really about centering our traditional ways of being and knowing into everything that we do, whether that be data collection on our urban Indian health side, our epidemiology side, or in our workforce development. It really means creating cultural spaces in our clinics and with the people who work there in a way that whether you're native or non-native, when you come in, you feel like you're a relative. You're treated like you're a relative. In our building, we do smudging of medicine with our traditional Indian medicine apprentices every morning and every afternoon. And we started that in the pandemic. We knew that it was really important during that time to kind of bring back some of our teachings, especially when it comes to the way that those medicines actually do cleanse the air. And so our apprentices will go around the building and they'll smudge our staff and our relatives if they're interested in that at that time. And I think it's a way that all of us, native and non-native alike, have learned that cultural way of being and use it in our everyday work. And so I can be in the busy clinic and they'll come around and I have to stop what I'm doing. And I just take in that medicine and I sort of ground myself again. So we've really partnered with community orgs in the area to bring cradle board making classes. They happen, every 3 months. And so while you're pregnant, you're definitely going to have a chance to make your baby board and also learn the teachings behind that. And back to sleep during that cradle board making class, we talk about the teachings and about how you pray into your child as you're making that cradle board. And so people who may not have been connected in any sort of way or maybe don't know how to make their own cradle boards from their own tribes can make a cradle board. And it may not be the exact one that their tribes use, but it is something. And so we brought back cradle board. We've brought in Indigenous childbirth education classes. And something that I'm really excited about is how we're going to be creating a space for our birthing people to have group prenatal care, but really with a traditional health curriculum to it. And in an urban Indian setting, I'm really interested to see how we're going to do that in a way that feels, open, that whether you come with a lot of traditional experience or you don't, that everybody can be welcomed into that circle. and really excited about people being able to create bonds with other pregnant people in that prenatal period, but then we're going to extend it into 1 year postpartum and also include babies into that and really talk about parenting and are we taking care of ourselves, our mental health. And we plan to interweave traditional ways into the curriculum itself.
A lot of our proactive preventive health will incorporate Native teaching, including what first foods to incorporate into a healthy diet, getting kids out into summer camps where they'll do traditional art, craft, dance, learning some of the language, I think is just so critical to lift up those community partners and work with them. And several of our health centers that do that. I think it's very humbling to learn from Native culture. And as someone who went through the Western medical training process, you sort of follow the protocols, you color between the lines, and you realize that this has been done for centuries. Medicine has been practiced for centuries in so many different cultures, in so many different ways. And there's so much we can learn from it and take away from it and incorporate into our practices and make us stronger providers and examples, that we can share with the community. I also look to the community, and I look to our community members who can provide those pieces of traditional teaching, even if I'm not in a setting where, I'm with a Native community. And for example, our traditional healers at the hospital will provide smudging services if requested, that they have a healing garden that's accessible for families as well.
Many American Indian and Alaska Native women find it hard to trust healthcare professionals because of the challenges they and their loved ones have experienced in getting the care they need. In my career, there was a time period that I did do a large amount of OB and worked in tribal communities and Indian Health Service and the private practice. And there's this common interesting notion, at least around the Southwest, that Native women are very, quote, stoic, and they're not going to be they're not going to express pain the same way as the dominant society or other cultures. And to some degree that may be the case, but there were some clear examples in my career where Native women were not offered pain medications or epidurals or the same sort of care plan as non-Native women that were treated in the very same system, that very same facility. And it was explained as a cultural thing to me from being from that culture that no, Navajo women, they don't want pain medications, they don't experience pain in the same way culturally, and so that's not something we typically offer. And so I found that to be, and this is not long ago. So, I mean, there's still many perceptions of our culture and our cultural ways that are not handled equitably in healthcare.
One of our relatives was pregnant with her 5th child, and she could come across, just like you said, as being really stoic. And is she depressed? She has a flat affect, we would say. And when she presented to the hospital in labor, she brought her partner, and her partner was sleeping, sort of on the couch, and she was in labor, and she was quite stoic and sleepy herself. And so the nurses started getting suspicions that she was using drugs, because there were notes being put in her chart that she seemed sleepier than she should be in labor, and that her partner was sleepy. And so even without her consent, they were charting about how they were going to obtain a urine drug screen. And I remember watching those notes from the clinic, so sort of seeing that she was in labor, and I was firing messages to the staff to say, you need to take those notes down and you need to talk to her. because it's completely unacceptable to make these assumptions without having a conversation with her. Maybe she wasn't okay. How is she? Is she in pain? Is she okay? Is she just tired because she has 4 kids at home? And so there were so many assumptions made. And because of the notes that were put in her chart that were not redacted, it required that she got a social work referral in the hospital, which then led to a CPS referral for no reason, because her urine drug screen that she got without her consent came back negative. And no one ever just talked to her or just allowed her to be. And so that was really difficult. And fortunately, it all worked out for her. But she had so many hoops to go through that were so unnecessary, just because of her affect and her partner's affect and the color of her skin. So no matter what piece of the team you're on, speak up. Speak up if that person is not being heard and listened to and respected. If their body is not being treated like the sacred vessel it is, speak up and slow down. Mm-hmm. So I would hope that when people come in, that they feel safe, knowing that they're seen for who they are, and that people are really trying to give them the very best care. Our women deserve to feel safe and taken care of. In the hospital that most of our relatives deliver in, it is very difficult to get them their placenta. You have to do a bunch of paperwork, and almost always the experiences where I would really try to advocate for a woman to be able to take home her placenta, it would almost always get tossed, even when we were very clear from the beginning. And I think just that complete disregard of how important that is to someone, it's complete cultural harm, because that's a really important teaching for our people. So that was one thing that I saw a lot happening in the hospital where I worked. I think that we all represent, different types of systems that people may navigate or come to, because one size does not fit all. And I think that more and more, as we're seeing the harms that are being done for our birthing people in places like hospital systems, we don't have what feels like a comfortable or safe place for a lot of people to deliver. They have to deliver in hospital systems, but we have to make those hospital systems work better too. And so I love the work that you're doing in trying to get more humility training to everybody. And I think it's also about how do we create more places that people feel safe. And so, we're really looking at birthing centers. We're really looking at expanding on midwifery, because that's not something that we have. But I think midwifery in itself brings a whole different mindset that I think a lot of the people I take care of in my clinic are looking for. And so I love that this table here sort of represents a lot of the different areas in which our people are seeking care, and how all of those are really important to make feel more culturally attuned and safer for people.
I think the best care, of course, is that if a Native person can be sitting across the desk or exam table or the kitchen table with a person that knows them and knows their beliefs and understands them in that sense, that's most effective.
I think what we really try to do, where I'm at in our urban Indian organization is, we have so many different tribal representations coming in for care, and we also take care of non-natives as well. And I think what we really try to do is center our traditional ways of being and knowing into everything that we do. Workforce development is a really key part of that. It's making sure that we have people who are caring for our patients, or as we call them, our relatives, who look like them and who have that shared experience. And we have a long ways to go in Indian country to really try to get more practitioners, nurses, pharmacists, you name it, we need it. And I think first and foremost, it's about really investing and trying to get people who have that shared experience at the table, like you said. And then it's about really bringing along our non-natives into the mix too, because we need everybody. So many of our people are seeking care outside of our walls.
As a non-native provider, I look to our Indigenous colleagues. We are always learning from them. I find that when I look to them to guide the practices that we've introduced, whether in IHS, for example, we are proactively looking to hire more Indigenous midwives because we know that, for example, here in Navajo area, with a higher number of Indigenous midwives, there are lower primary C-section rates as well as higher successful VBAC or vaginal birth after cesarean rates because of that trend towards traditional and holistic birth. And I think that's where we need to look towards in the future, whether it's with Indigenous midwives or Indigenous doulas. We have looked to our neighbors in Alaska with the CHAP program, the Community Health Aid Program, that does such great work lifting up members of the community to be health advocates for the families that live there. And so looking to incorporate more of those pieces into what we actually call a maternity care coordinator program. And this will be someone, a member of the community who's actually following a relative through the pregnancy period and that critical postpartum period, ensuring that they're, tracking all of their referrals, addressing all of their social needs, and transitioning in that postpartum space.
I think about 3 or 4 years ago, I started working with a large state organization of perinatal workers. And during their yearly conference, was able to continue to provide not only a continual dialogue, but to provide training toward, cultural awareness and in their jobs and how that might interface and how what kinds of things would they need to know. And so that's really brought us to a different level of understanding for, 300 or 400, they're actually service providers in the medical system, but they're willing to take that information in as a result of some other training. So we can still do our part in terms of providing that education or that awareness in terms of in the level of training. And that brings, especially in states where there is a large Native population, we both need to meet at the table, right? Like those of us that can provide the cultural training, cultural sensitivity or cultural knowledge training, whatever we want to call it, and those that are willing to take that training on a continuum, because it really is, you can't get trained once to have cultural competency, right? You have to have it on a continuum. And so one of the things that's very important is to first acknowledge that there's something wrong, and then to move toward training that can help to make people aware. Those that wish to be trained and are open-minded and like you said, curious and willing to look at how to make the system better, because clearly the system is failing Native women and in this country. So how do we do that? Well, cultural safety, again, there's something that has to be. You can't just have one training and say, okay, I've got my cultural safety training for the year. It's something that has to be. It's critical that training happens on a very grand scale or large level, that it maybe there's an implication for it in the training of medical, in the actual institutions that teach about medicine, because something has to give, because it's ingrained, in terms of how it has really infiltrated like every aspect of our society. So undoing that is not going to be an easy task. I think that we all are in this work, and we have been in this work for a long time, and we see that problem, and we probably have all attempted to bring forth that change that people can make in themselves and how they treat others in terms of their medical practice or in terms of serving the population that they're serving. So yeah, I think that there's a really big part of that should be training.
When you say undoing this, you're essentially saying one of the first steps before you can even be curious or even be open or even look at something else is you have to look inward, and you have to understand that we all have implicit bias, and we all have to be introspective and beyond that and figure out where are the microaggressions that I carry, and how do I handle that in my work environment? How can I break that cycle personally? And that first step is essential, because oftentimes people don't recognize that they may be doing something that's discriminatory or racist. That's not a conversation that is acceptable in our culture, and it's not something that is rewarded. And so having a culture of safety where people can acknowledge some of these implicit biases that we may all have, or that we do all have, is really the critical step to begin with. I think one other point, when we're looking at our Western medical model, we see this very paternalistic model of care that has evolved in our society as what is perceived by many as the superior way to do things. And so when you're trained in a very specific model of care that you have strong beliefs in, it's very difficult to deviate from that, particularly when you're in an uncomfortable situation or a high pressure situation. And so understanding that we are here to support our patients and our women, and we are not saviors of these communities. We are here to recognize the strengths, to see the power in what's already present, what already exists, and truly hear our patients and be that advocate in that support system in those situations.
I think that holistically supporting a group of people in training that would look at themselves internally and say, okay, maybe that's why I handle the things the way that I do, or maybe it comes from this area of my life or this part of my training. And so to self-explore can be a powerful thing and can enrich people to no end.
And that's another element of cultural safety. We've been focusing on cultural safety for the patient and the community, but cultural safety, a culture of safety, needs to be present in our medical training, in our meetings, in our businesses, in our society, so that people do feel a little more comfortable making people uncomfortable by asking these questions. And we're not going to see change without some of these uncomfortable conversations.
We do onboarding for our staff. We do a whole week of onboarding where all of our staff learn the history of healthcare in Indian country, and especially what it means, and some of the relocation acts and things like that moved a lot of natives into urban areas. Like, why did that happen? And we actually teach the history of that to all of our staff. And they get a deep dive into what they call Indian Health 101. It's almost like they get a college course in a week of what it means to take care of Native people in an urban Indian site. And so I think it comes down to the way that we train our staff, that we center our staff in our traditional ways so that they're the face that everybody is going to see, but they are grounded in that medicine themselves. Whether you're Native or non-Native, you're going to get that same experience as an employee. And what I'm really excited about is how we're transitioning that into our maternal child health space. And so we really look at how can we bring those teachings to our birthing people. When we do right by our Indigenous birthing people, that will translate into the U.S. and their rates also improving. If we can focus on lifting and empowering the ways of Indigenous birthing, the ways of being and walking in the world. If we can elevate this voice, it only is going to help everybody, right?
So honored and humbled to be here and in your presence. And
Thank you.
no woman should die giving life. And that's why we're here. With all the work that you're doing, we are one small part of the solution. So thank you all so very much for participating in this extremely important initiative. This campaign was titled Hear Her for a reason. You are all being heard. We are being heard. And there's so much more that we need to do, but so much is happening now. And it's just very exciting. So thank you all for all of your efforts.
I really needed somebody that would listen to my concerns as well as take my thoughts into consideration, which my doctor did. And it took me a long time to find her and to find somebody that I actually trusted.